By way of introduction, I'm going to welcome you to Physicians Regional Hospital here in Naples, Florida. My name is Robert Zehr. I'm an orthopedic surgeon. I've been here in Naples now for 12 years. I was part of the Cleveland Clinic when I first came down here. The last 3 years I've been in private practice, and I primarily focus on dealing with hip and knee replacements. The take-home message of this early part of this talk is to keep your own joint as long as possible. You're not here to give up your joint to a surgeon. Your job is to keep your own joint and stay away from guys like me if you can. So keep your own joint as long as possible is really the take-home message here. So if I say nothing else tonight that interests you, please take that message and sleep on it because it's very important. Okay, I'm going to speak a little bit to the topic of exercise because people invariably want to know, what do I mean by exercise? I've categorized it into 3 little subsets. First being some form of flexibility, and that could be everything from just cracking your neck in the morning and kind of loosening things up, and you walk across to the kitchen and your knee feels better after you kind of lube it up. That's because when you're not moving, any fluid that you had in there sort of disappeared, the bones stuck together, and when you walk, you're forcing fluid back between those bones, and it feels better when you take 20 or 30 steps. Stretching kind of is everything from yoga, tai chi, or just doing general routine, stretching all your tight joints out. Strengthening is pretty self-evident, but it breaks down into isometric and isotonic. And what those terms mean is isometric means that you do something like this. You pull real hard, your muscles aren't really moving, but they're contracting. So this little cartoon fella here, quadriceps are tightening. He's sitting up against the wall there, but they're not really moving, but I guarantee you they're tight as a piano wire. Isotonics, where the muscle's actually shortening and lengthening as you go up and down or when you're curling weights. That's isotonic, and that's what his shoulder muscles are doing. The last and most confused is some kind of aerobic or cardiovascular work. So riding your bike routinely 4 or 5 miles, and certainly a stationary bike is safer. If you've got balance problems, there's nothing wrong with a stationary bike. Swimming is always the one that amuses me the most. That guy's swimming. Michael Phelps swims. People that tool around in their little bathtub pools with a drink in their hand on their little noodle does not constitute any form of exercise that I'm comfortable with. So please understand that swimming is a real exercise, but you can't just noodle around your pool. You have to swim. And dancing, a lot of people love to dance. I always say that guys over 6 feet tall ought to be careful out there because I'm not worth a darn dancing, but that's real dancing, popping around there and dancing like you used to when you were younger. Those are all just typical examples of ways to get your heart rate up and your lung capacity going. So if all else fails, eat less, more exercise, most ridiculous fad diet I've ever heard of, I think you ought to come in and talk to somebody because you're armed with a lot of this information. You've tried these things, they're not working, so what else can I do? So that's a reasonable time to come in and talk to a surgeon. So with pills, exercise, weight loss, and just flat out putting up with it just isn't cutting it anymore, and your quality of life is going downhill, I think it's time to come and talk. Make sure that when you speak to any surgeon, he spends enough time talking about, well, what else can I do? I've tried this, this, and this, and if you've tried all those things, flat out, I'm going to tell you either live with it or we operate on you. And I've had to do that on occasion. But more times than not, people come in and have never tried any of those things that we just spent a half an hour speaking about. You ought to know if he starts warming up his operating hands there, what can go wrong. And you ought to have some concept of what is a realistic outcome. Somebody that's never run before in their life, getting a total knee, you're not going to be running the Boston Marathon the next time it comes around. So my job is to kind of go over all of this and make sure that your realistic expectations are cemented. We want you to feel confident in your decision, which means when you're lying there in the operating room upstairs, you don't come and say, Doc, am I making the right decision right there at the last minute? When that happens, I missed somewhere along the line communicating to you. So you should be gung-ho, ready to go, know you've tried everything possible. That's confident in your decision. You have to be willing to put in a hard time. Anybody here want to admit that they had a knee replacement? Any gutsy people? Right. You know what PT is all about. That is the hard time. If you've not had your knee replaced, this concept will likely escape you. Those of you who have had your knee replaced will understand that when the therapist is pushing on your knee, you're not laughing at jokes. That's a little uncomfortable when they do that the day after surgery. So this is you, and this is your therapist. So those of you who have had your operations, you can get this a lot better than some of you who have not. Okay, these are some fun facts that you ought to take into consideration when you start hearing the government start cranking back on dollars and things. But the volume of knee and hip replacements are going up in a staggering fashion. In the last year or so that we've had statistics, the quotes vary somewhere between 700 and 800,000 hips and knees are done every year in the United States. That volume is projected to go up by the time I'm at an age, hopefully, that I need one of these, to be in the 600 to 700% increase in knee replacements and 100 to 200% increase in hip replacements. Knees, again, far more likely to be done than hips. So that number is just staggering. That's the graph depiction of how many joints, knee joints, are going to need to be done in the next 20 years, and that's roughly how many hips. And then probably as important is this concept of doing revisions. That means the first one we did doesn't last. Everybody that's looked into joint replacements, the question always comes up, how long is this going to last? So the ones that don't last to the end of your days are called revisions. We have to revise all or some part of the joint. And that constitutes anywhere from 8 to 10% of all the joints that are done every year because they've been failing since the 70s when they first went in. So that number is going up a staggering but similar rate as the primary joint replacement. So these numbers are really quite mind-boggling, particularly when you can realize, as the Orthopaedic Academy publishes virtually every year, that 80% of all the joints that are done by guys that do 1 or 2 a month. So when I'm doing somewhere around 12 a week, that's more than 1 or 2 a month. So there aren't down here in Naples, there's several guys that do a big volume because this is God's waiting room and lots of people need their knees and hips done. But if you're in the middle of backwater Missouri, where I grew up to some degree, the guy may be doing all different kind of things from bunions to shoulders to wrists to elbows to knee replacements. And a high percentage of the joints are done by guys that don't do a lot. And why that's important is when you start seeing some of these fancy surgical procedures I'm going to present, the guy's not going to be doing fancy surgery procedures. He's going to be doing them just the way he was taught, which is safe, stay between the lines, and don't screw up. So that's kind of how they'll work. So we're going to get from what do you do to stay away from me to good, come on in, let me talk to you a little bit, part of this talk here. And we're going to go over how do we do hip replacements, how do we do knee replacements, and how do we do these things that are a little bit unknown to most of you called partial knee replacements in those subset of people who would qualify.